So the main aim of the Optimise II trial is to really once and for all answer the question, is that cardiac output guided fluid therapy and algorithms guided by cardiac output monitoring definitely going to improve outcomes for patients having major gut surgery or not? It's something we've been debating for a very long time, and it's about time we got to the bottom of the answer. So the primary outcome measure is hospital-acquired infection, and we've categorised in that the most frequent hospital-acquired infections, which are mainly surgical site infection, pneumonias, urinary tract infections and so on. So we've predefined those principally most common infections. And then there's a series of secondary outcomes, perhaps most important of which are the safety outcomes. We're looking at cardiac events after surgery, because one of the big areas of controversy of these kinds of treatments is that they cause harm to the heart, they might cause heart failure, they might cause myocardial injury and so on. So we're looking at safety outcomes. We're also looking at features like acute kidney injury and so on as well. I mean, I guess Optimise, you could interpret it in lots of different ways. When you write a paper for a big journal like JAMA, which is where Optimise was published, you can't sort of say there was a trend to this or as a pattern of that. It either worked or it did not work. And what you actually saw in Optimise 1 was a treatment effect that was quite large, but not statistically significant. Now, that means it didn't work. But if you looked at certain categories of patients, for example, hepatobiliary patients or the patients having elective surgery, you could see that although we hadn't prospectively analysed it in that way, you could see that the pattern of outcome was significant. And in essence, one very legitimate interpretation of that trial is it was simply underpowered, and if we'd had just a few more patients, or if we'd excluded some of the groups that didn't respond, like emergency patients in a certain way, then that we might have had a trial that showed a significant benefit. But as far as the journals are concerned, it either did or it didn't. So it's very hard to provide an evidence base that's going to definitively change practice if the interpretation of those findings remains quite controversial. And so what we're really seeking to do in Optimise II is to give people the answer they seek once and for all. That people like me can stop presenting on this at conferences, can stop writing papers on it. We can just get on and do what's right for our patients and give them the care that they need, and that we can put to bed the debates about benefits and debates about harm. So, I mean, as a chief investigator, of course, as you know, you run these big trials. You don't stop worrying from the day you put them together to the day they get published in whichever journal they get published in. You can't run these big projects without a tremendous amount of support from the investigators' individual hospitals. And we're really dependent on just a huge amount of help from people like that, and they do a great job for us. The things that we find ourselves asking for particular help on are to make sure that when you deliver the trial protocol, you deliver it exactly as as closely as reasonably safe to deliver what the patient is randomised to is what the patient gets. And it can be quite difficult if a hospital doesn't offer the patient the treatment they were allocated to when they were randomised, and that can be quite hard. So we need to look at that quite closely, because the thing is, we know that some patients won't be able to have that treatment for some reason. If they have a big complication, maybe they bleed torrentially on the table and treatment just goes down a different route because they're too busy doing other things to think about the trial. That's understandable, but we need to make sure they are the exception, not the rule. And probably the second big thing is we need to make sure people follow the patients up and give us the data. So if we don't have the primary outcome data for a given patient, then essentially they're useless to us, because if we don't know what happened to them, then we don't know whether the treatment worked or not. So those are the sort of big areas that are really important. Crumbs. I mean, they're big projects and they're just very exciting to be part of generally. It's a huge honour to lead what's essentially a community endeavour. I mean, we wouldn't be doing Optimise II if there weren't a lot of people who felt it was important and worthwhile, because we simply wouldn't have enough money to pay everybody to do this just as a job of work. The people who are helping us because they believe it's important and they believe they need the answer, and they're prepared to give up some of their own time to see that happen. And so to have the chance to lead a trial on behalf of people like that is a big honour, and that's very, very exciting. Of course, as a researcher, I'm desperate to find out what the answer is.